Hello, I'm Dr. Steve Kopetsky, a preventive cardiologist at Mayo Clinic in Rochester, Minnesota, and I want to welcome you to another one of our interviews with the experts prevention series. Today, it's my great pleasure to introduce my colleague and friend, Dr. Afan Irfan, who's an assistant professor of medicine. He is very involved in our prevention clinic, our echo lab, in our outreach treatment efforts. So, welcome, Dr. Irfan.
Thank you, Dr. Kopetsky. Thank you for having me.
And today, the title is Obesity and Hypertension Risk Factors in Terms of Prevention and Decreasing the Risk for HFpEF, or Heart Failure with Preserved Ejection Fraction. So, Dr. Irfan, what is HFpEF and what are its risk factors?
That's a really good question to start off with. What I would do is I will go back to the basics, just to remind everyone that, as you know, the heart has four chambers. So we have two top chambers, the atria, two bottom chambers called the ventricles, and the right and left side. So typically, with every heartbeat, each of these chambers is supposed to contract or squeeze, and that is the systolic phase. But then each chamber also have to relax, and that's the relaxation phase or diastology. So the cardiac function or the ejection fraction, when we talk about, we typically refer to the left bottom chamber, which is the left ventricle. But there's so much other things going on as well. There's three other chambers, and there's a diastology part as well. So that ejection fraction, typically the number that we look for is about 50%. Slightly above 50% is considered normal. So that 50% is the percentage of blood that is pumped out from the left ventricle with every heartbeat. So the rest 50% remains in, that fills it with the next heartbeat. But what is interesting is what many people don't realize is the diastology part or the relaxation part is also equally important. And that is where actually most of the energy is actually spent. So if there's any problem either in the systolic phase or diastolic or the relaxation phase, both of them can lead to heart failure. So with that background, now let me talk about the heart failure itself. What is heart failure? The term heart failure refers to the inability for the heart to pump blood effectively to meet the body demands. So I'll come back to this about what does it mean at rest or with exercise, but it could be either. It could be just at rest, which is much more later forms of the disease. It could be early on as well. It could just manifest with physical activity. And this then typically leads to the classic symptoms that we know, which is shortness of breath, getting tired easy, and swelling. Swelling is typically in the legs. That's the extra fluid overload. So way back in the past, we just focus on the heart failure subtype, which was the cardiac function or the ejection fraction if it was less than 50 or less than 40%, where now it is called reduced heart function. But now we know that heart function, even though normal or preserved, if it stays above 50%, can still have heart failure. And that is the preserved ejection fraction. So the way the heart failure is now subdivided is less than 40%, it's reduced. More than 50% is called preserved, and 40 to 50 is the mid range or mildly reduced function. And the important thing is that the risk factors between the two is also different. So typically, for the reduced ejection fraction, the more common risk factor is coronary artery disease or heart attacks. But with the heart failure with preserved ejection fraction, we have this growing burden of chronic conditions, namely hypertension, obesity, chronic kidney disease, other metabolic disorders. And all of these are growing in burden. And so is, as these risk factors are growing, so is the burden for HFpEF or heart failure with preserved ejection fraction. In fact, now we are seeing that of all the heart failure types, the HFpEF accounts for 50% of all heart failures.
It's almost a term we use loosely, but probably wrongly, diastology, calling it relaxation. It really isn't relaxation. It takes more energy than systole. That's fascinating. So the risk factors for HFpEF, you mentioned obesity, hypertension. How common are those, in the general public? And then how common are they in people with HFpEF?
Well, yes, those two risk factors are known to be the most common, most prevalent, strong risk factors for HFpEF. Obesity itself, as you know, nearly half, 50% of US adults have hypertension. And this is the strongest risk factor for HFpEF. So those patients with HFpEF, we see hypertension up to 80% among them. In fact, as you know, HFpEF was first recognized as a cardiac disease for hypertension. So the same findings that we see, either symptoms or signs of symptoms, we in patients with chronic hypertension and cardiac manifestations, we see that in HFpEF. But we know hypertension is not the only cause for HFpEF. So which is now it is more rightly caused HFpEF rather than hypertensive heart disease. So 50% of US adults have hypertension, and among HFpEF, 80% of them have hypertension. As for obesity, almost again 40% of the US adults have obesity, and almost double, again 70 to 80% patients with HFpEF have obesity. So it's almost doubles the risk with obesity and almost 2 to 3 times with hypertension. One of the reasons why hypertension and also obesity contribute to the development of HFpEF is because of the excess body mass and fat and the blood pressures that the heart has to pump against. So this then eventually leads to thickening of the ventricles. It causes more stiffening. And then eventually leads to problems in the relaxation and filling problems. In addition, these chronic conditions, hypertension, even obesity, they also lead to chronic inflammation and metabolic changes. And that further increases the likelihood of HFpEF. So these factors are growing with time, and so is HFpEF as well.
Very good. So how do you diagnose HFpEF?
The diagnosis of HFpEF is not as straightforward as you can imagine. For reduced ejection fraction, we know we can rely on a calculated number. If it falls less than 40%, we call it reduced ejection fraction. But HFpEF, the term itself, has a normal value. So a preserved ejection fraction, that means the ejection fraction itself is in the normal range or more than 50%. But that is the systolic phase that we're talking about. So the diastolic phase, or the relaxation part of it, more appropriately called, if that is abnormal, that will lead to the classic symptoms again. So it is more of a presence of symptoms together with the presence of risk factors. So again, I would specify again the symptoms that we look for is the shortness of breath, feeling tired, easy, or fatigue, and then swelling. And together with the other risk factors, diabetes, hypertension, obesity, all this, and there are some clues on the echocardiogram and some lab testing that can suggest some stiff ventricles. But they can be missed, especially if it's early part of the disease. So that's why in certain cases, we might have to move forward with a cardiac stress test. So when we stress the patient in systolic or diastolic, those conditions can be unmasked. The filling pressures can be normal at rest, but with exercise or physical activity, the filling pressures may be higher, and that is the ineffective blood pumping. And that also can cause the heart failure, but typically those symptoms only occur with exercise or physical work. And in certain conditions, cases, we might have to reach out for the gold standard test, which is the right heart catheterization. That is when we're going with a catheter up to the heart chambers and measuring the pressures. And that way we can find out about the stiffness and the capacitance of the heart.
Do we ever see elevations, or do you standardly check NT-proBNP?
NT-proBNP, if even if it's normal, does not mean that the patient might not have it, especially if it would be at rest. We have this HFpEF score that again has a combination of things that we look for, and it includes BNP as part of that. But again, none of these parameters, presence or even absence of it, would mean that the patient absolutely have HFpEF. So having positive biomarkers does not mean that they absolutely have it. It just suggests that they might have a higher likelihood of having the disease. But yes, we do check BNPs in them.
So you mentioned that weight loss or overweight, does weight loss help? You mentioned hypertension. Does controlling hypertension help? You mentioned exercise or lack of it. Does exercise help treat HFpEF?
Yes, lifestyle changes is the cornerstone for HFpEF in preventing the disease, managing the disease. So since I just talked about obesity and hypertension, these are the two most prevalent and modifiable risk factors for HFpEF. So lifestyle changes significantly lowers that risk. We know from many studies that losing as little as 5 to 10% of body mass
Mm-hmm.
can lower the blood pressure and in fact improve the relaxation phase of the heart. Certain diets such as the Mediterranean diet, particularly those that lower sodium, which is the DASH diet, they're effective in lowering the blood pressures and reducing chronic inflammation. Both these two diets, they focus on having plenty of fruits, vegetables, whole grains, healthy fats, and at the same time, the more important thing is also to limit processed food and excess sodium. So diet is a really important thing in preventing and managing this disease. Of course, more the salt, more fluid overload, and more will be the symptoms. Regular exercise and avoiding sedentary behavior is also very important, and it has to be a combination of exercises. So and some aerobic exercise, strength training. In fact, one of the type of exercise, which is the HIIT training, high intensity, high interval training, seems to be also really helpful in patients with HFpEF, especially early on in the disease. So simple lifestyle modification, even just walking to work as you parking your car far away from your office,
Mm-hmm.
taking a staircase if possible. All those things will help reduce the sedentary behavior, and it's important. So it is not only exercise, but also avoiding sedentary behavior, and together with diet, all of them are important changes to help reduce that risk.
And then what about SGLT2 inhibitors?
Yes. Again, cannot emphasize enough how important is lifestyle modification, and that is
Mhm.
always the cornerstone. So always that is helpful in preventing the disease, managing the disease. So after lifestyle, whatever can be done, now we know we have this new class of medications, which is the SGLT2 inhibitor, which is a sodium glucose co-transporter inhibitor. This was just approved a couple of years ago by FDA, and which is why there's a bigger push on making this HFpEF awareness, because now we also have a treatment available as well. So, as you know, like I mentioned, for the longest time we thought of this as just a hypertensive heart disease, and so the treatment options were limited to medicines for to treat hypertension. One of those were also the diuretics, which is the water pills. And these water pills, as you know, they work on the kidneys and prevent it from absorbing sodium. So you pee the sodium and the water goes with it. So these
Mhm.
SGLT2 inhibitors are very similar. They work on the kidneys, but instead of only sodium, they also block the glucose as well. So that's how they have really a large beneficial effects. In fact, they were first approved and still being used as the first range of medications for type 2 diabetes.
Mhm.
So it helps in controlling diabetes in chronic kidney disease as well, and in heart failure in both subtypes, maybe systolic or the relaxation preserve ejection fraction. And it also helps improve the relaxation part of as well.
Now, what medical and public health strategies can help reduce these factors and reduce health HFpEF?
The biggest thing would be awareness and educating the public at large. So just like this podcast that we're doing, getting the word out, also making sure our primary care offices understand this as well, that the growing burden of this disease. So education is the primary thing. Also,
Mhm.
at the same time, focusing and promoting physical activity, avoiding sedentary behavior, improving nutrition is the key. As you know, with time, there's increased burden of these chronic conditions, which is namely obesity and hypertension,
Mhm.
and it is still growing. Even childhood obesity is still growing. Educating our public at large. Teaching them about how to limit these added sugars, saturated fats, and excess sodium, and processed food in general should be avoided. So those things are important at the public level.
Well, this is very interesting and great information, Dr. Irfan. And to me, it's very interesting that obesity and lack of exercise are also risk factors for cancer, but the treatment is not losing weight and exercising more. But in HFpEF, it's both a cause and it's a cure. to lose weight and start exercising more. So that's a very positive. That's a disease that we can deal with individually.
That's right.
Well, this has been great information, and we greatly appreciate you taking the time to talk to us about HFpEF, especially obesity and hypertension. This will be great information to give our patients and to give our referring providers. Any last words of wisdom for our providers today?
For our providers, I would say, especially this disease can be missed on if it's not on your radar. So early part of the disease would be easily ignored and would be chalked out to say just being obese, and that's why you're not working out enough and you're not pushing it enough. But keeping in mind that these risk factors are very common in HFpEF, so early diagnosis detection is really key, and then also emphasizing lifestyle changes and reinforcing the importance of healthy lifestyle is really important.
Dr. Irfan, thank you for spending time with us and educating us today. And thank you to all our listeners for listening to us today. We hope to see you again soon.